Oh, I've just heard that saying we're now being recorded. So for those who have just joined on the recording, I'm really sorry. We've just gone through a case really quickly about a child in septic shock, and we're just talking about starting inotropes in A&E. So we were just talking about what start, when start, and what access do we have. So as I was mentioning, peripheral inotropes, really dopamine versus adrenaline probably would be what I would say most of us are familiar with, probably dopamine more so. And then I guess the question is also what's available, what are the team comfortable with using? You might be in a DGH where you don't have nurses that are happy drawing up some of these drugs or that have never done it before. And so sometimes actually reality needs to kick in a little bit, and while you might want to start one thing, or you may have just done your PICU placement and you know that actually you can give this drug peripherally, or you would really like to put in a central line, actually that might not be the reality of what's happening in front of you. And this box here, what I sort of highlighted, was actually what I kind of want to talk through a bit about, because what I think is really important, which sometimes in these sort of situations where, you know, everyone's running around and there's a very sick child in front of us, it's easy to forget maybe actually why we're doing what we're doing. And inotropes, I think it's really important when we start thinking about them to think about what we're using them for, what are we trying to do, what's the underlying physiology, and actually what is the best drug to give in this situation. As a just quick sort of survey, not really survey, who's used to using inotropes in A&E? Have you guys started inotropes before in A&E? You guys presumably work in A&E or pediatrics, which is why we're here. Yeah, fine, great. And presumably a lot of you are used to using dopamine as a first port of call, I would guess. Yeah. Great. Fine. That would be what I would think is probably still common practice. So these are a couple of emergency drug calculators. You guys may well have seen these. There was also for London Children's Acute Transport, or the CAPS retrieval service in North London that have a drug calculator as well, but I haven't put that on here. So this is the South Thames retrieval service. This is South London's retrieval service. It's their emergency drug calculator. And as you can see here, they've got peripheral dopamine, central dopamine, central adrenaline, central noradrenaline, but no peripheral adrenaline calculation. The Children's Acute Transport Service do, and I know that because I've previously worked somewhere where we would call them. And this is the South Oxford, retrieval team, SORT. And they also have a calculation. Move that way so I can see what I'm talking about. For peripheral adrenaline and also central adrenaline on their drug calculator, just of interest really. And this is a couple of sepsis guides, just because actually this case was a sepsis case, but obviously we use inotropes for things other than sepsis. I don't want you to go away thinking that's the only thing we use inotropes for, but that's kind of probably the majority of what we would see. So this is, again, the Southampton Oxford Retrieval Team's sepsis quick reference guide. And this sort of talks about fluid refractory shock. So starting fluid first, if you're not responsive to fluid, or you're still giving lots of fluid and the child's still in shock after giving lots of fluid, then to attempt central access, but and to give, depending on the type of shock, to give noradrenaline or adrenaline. And this is the South Thames Retrieval Service, and this is again their sepsis guideline. And this talks a bit about fluid refractory shock in this sort of early stages, and talks a bit about peripheral dopamine. And that's, I guess, that's their kind of go-to drug peripherally at the moment. And then after you've gained central access, to start with something a bit different, noradrenaline or adrenaline, depending on the type of shock. So inotropes and vasopressors. We, I think, band around the term inotropes a lot, and I think we call a lot of these drugs inotropes, whereas actually there are drugs that have inotropic effect and there are drugs that have vasoconstrictive effect. And I think when we think about why we're using these drugs, it's important to go back to our basic physiology, which I have to say I am terrible at the best of times, but try and think through these equations, which we will all remember, I'm sure, from medical school or pediatric intensive care, A&E, if you use them there, and just think about why we're doing what we're doing. So our mean arterial pressure is our cardiac output times our systemic vascular resistance. and our cardiac output is a factor of our heart rate times our stroke volume. And actually, if you delve into stroke volume is influenced by the preload, so how much you're filling the heart, the contractility of the heart, and actually how much the heart or what the heart's pumping against. So if you think of the heart as a pump, you need to put a certain amount of fluid into it. You need to have a good pump with a good contractility, and it needs to be pumping against not a huge resistance to pump well. So obviously all those things we can influence to a certain degree, and these drugs can help do that. So vasopressors, which is quite an American term, I guess, or vasoconstrictors, are drugs that are going to increase the systemic vascular resistance, and that's really how they're going to help increase our blood pressure. So in our child with warm shock, who is very flushed and vasoconstricted and has a terrible blood pressure, for all of the people working at the moment, you may well have or have not, but I'm sure you have heard of the PINS TS patients that are coming in with sort of toxic shock type symptoms. And a lot of those have a low blood pressure and are not necessarily cool peripherally because they're in a sort of warm shock, almost like toxic shock, like you would see with toxic shock. And so actually in those children, they've got a low systemic vascular resistance. So we're trying to increase that. So that's thinking about the drugs we might use in them might be slightly different to a child in cold shock, or would be different. The thing to think about with these drugs, or to remember, is that actually if you're increasing the systemic vascular resistance, you're increasing the afterload, or the what the heart has to beat against. So you're affecting your afterload if you look at this equation down here. Inotropes are, a positive inotrope is just something that increases contractility. And so inotropes, when we talk about the inotropes we use, they're increasing the cardiac contractility, so the contractility of the heart, and therefore improving cardiac output through that. And they do that by increasing cycling of calcium in and out of cardiac muscle, if you want to get down to the nitty-gritty. And then chronotropes, of which lots of inotropes have chronotropic effect as well. They increase the heart rate. So again, you could see if you look at mean arterial pressure, it's cardiac output times heart rate, then times systemic vascular resistance, and that cardiac output is influenced by heart rate. You could see why increasing the heart rate would increase the cardiac output. The receptor action that they work on. So you've got alpha receptors, beta-1 receptors, and beta-2 receptors at the very basic sort of thinking of it. Alpha receptors are generally in or located in your vascular smooth muscle and cause vasoconstriction. So that's what vasopressors or vasoconstrictors will work on. And then you've got your beta receptors, beta-1 receptors in your heart, which will increase your heart rate, will have this chronotropic effect, and also increased contractility, so the inotropic effect as well. And then beta-2 receptors, which can be vasodilators in many organ systems, and some of these sort of drugs that we use have a vasodilatory effect. Not normally the ones we use in A&E, but things like milrinone, which we're using down the line, may have a vasodilatory effect as well. So the ones I wanted to talk through really quickly that we probably see in A&E the most were adrenaline, dopamine, and noradrenaline. So adrenaline has equivocal activity on both alpha and beta receptors. So it's an inotrope and also a vasoconstrictor, which is why actually it's a really good drug to use, because actually it covers most of your bases, and in most situations probably will be helpful to these children, whatever type of shock they have. Obviously that's not entirely true in all situations, but generally in the child in A&E resus, when your back's against the wall, it's a pretty good drug to have to start with. So it's got equivocal activity on alpha and beta. It increases the heart rate and also the systemic vascular resistance, and therefore the blood pressure. And it can be given peripherally. Noradrenaline. So this is mainly alpha-1 activity. So this is mainly a vasoconstrictor or a vasopressor. And most significantly, therefore, it has got an effect on the systemic vascular resistance, and so it increases the blood pressure that way. So again, in these sort of children with warm shock that are very vasodilated, that you want to increase their also want to cause vasoconstriction, increase their systemic vascular resistance, this is a really useful drug to use. But just bear in mind that increasing this can lead to reduction in cardiac output, because if you've got a child with a very sick, poorly heart that is struggling and that has poor contractility, for example, myocarditis or another cause of that, then it may well be detrimental because you are trying to pump against a higher resistance. And so actually sometimes in those cases, which is why you may have seen it discussed in these patients with this PIMS-TS syndrome, you might use it in conjunction with an inotropic agent such as milrinone, which you will use to increase your cardiac contractility and sort of weigh up that detrimental effect that you're having by increasing the systemic vascular resistance. There's some evidence from the adult literature of short-term peripheral use, but there's not any pediatric evidence of that. If anyone does know of any, please do speak now, because I couldn't find any. And it's not a drug that generally we use peripherally. I don't think I've seen it once maybe in PICU, and we were absolutely had nowhere else to go with a child that was almost in cardiac arrest. But it's really not a drug that is generally used peripherally compared to the other two. Dopamine. So dopamine is a precursor of noradrenaline, adrenaline. It's got alpha, beta, and dopaminergic effect, so it acts on those receptors. And there's this kind of maybe slightly theoretical low dose dopamine, which you may have known of as renal dose dopamine, in which at low doses dopamine works mainly on dopaminergic receptors, and that can cause some renal artery vasodilation, which is why sometimes, although probably not in an A&E resus situation, but that might be used as a renal dose dopamine in some children. In higher doses, which is when generally we would be using it in A&E, it's mainly got alpha activity. And so that's mainly a vasoconstrictor as opposed to an inotrope, although it does have some inotropic effect. And it can be given peripherally. We know this, most of us have seen it given peripherally, and it's on most of the guidance. So this is just a kind of run through table that goes through all of these drugs, which is what I've just talked about, and just kind of talking about really when they should be used, what the sort of indications for them is, which we can think about based on what we've just discussed, and their actions. And just to be aware that they all do have side effects. So while these drugs, I'm trying to sort of encourage you in one way that actually they're safe to use, they're not without risk. So it's sort of worth thinking about this when we're starting them, and which is why it's worth thinking about why you're starting it and what the best drug is to use in that situation. I just wanted to mention push dose adrenaline or dilute adrenaline. Has anyone heard of dilute adrenaline or using push dose adrenaline? Yeah, Beatrice has. Okay, great. So some have. Okay, so I think it's something that as an SHO and a junior registrar, I definitely wouldn't have heard of. But as I've done more pediatric intensive care, I've heard of it. And it's something probably is becoming maybe a little bit more common practice, I would say. Although there's not much evidence for it, which is interesting. I was looking at it with one of the PICU registrars the other day, trying to find some evidence, and there's not much. However, the aim of this is not a cardiac arrest dose of adrenaline. So just to make sure that that is separated in this, the aim of this is to try and prevent cardiorespiratory arrest by giving a small dilute dose or small dilute aliquots of adrenaline. And really that's probably going to be just to buy you time whilst waiting for an infusion of adrenaline to be drawn up. Ideally, an infusion of adrenaline, because it runs at a constant rate and you don't have swings in blood pressure and things like that, is better. However, in an A&E situation where someone's gone off to go and try and find the adrenaline and find the guidance and draw up the dose and work out whether they've got a syringe driver and a pump and infuser, etc., this may well be the drug that gets you out of jail free in that situation. I think probably anaesthetists will be people who will be used to using these sort of drugs. This is the sort of thing that they may well use in a situation in theatre or something where they've given a drug that's dropped the blood pressure, child becomes hypertensive, or adult, and you give a little bit of an aliquot of something to counteract that effect. And they use other drugs as well for this, but the reason I mention adrenaline is because this is probably the one we would use most in A&E. Why adrenaline more than other drugs? It's probably a combination of things. It's probably the most effective in the majority of the scenarios. It's got inotropic and also vasoconstrictive effects. It's probably one of the safest drugs, and it's really available. It's on every cardiac arrest trolley in every hospital. So actually it is the sort of drug that you could get your hands on in an emergency, hopefully pretty quickly. There's not much guidance on how to draw it up. This is what we do at the Evelina or at STRS do. And there's other ways to do this as well. But basically what you're trying to do is you're trying to dilute down a concentrated adrenaline cardiac arrest dose. So one of the ways to do that would be to take your concentration of adrenaline, so your 1 in 10,000, which would work out as 100 mics per mil, take an arrest dose for that child, so 0.1 mils per kg, which hopefully we're all used to as a cardiac arrest dose of adrenaline, and dilute that up into 10 mils of 0.9% saline. So you're doing this at 10 times dilution. And then you're going to have a solution which is 10 micrograms in a mil. And so because you've made up a dose per kg already for that child, you can use 1 mil aliquots of that, and that will contain 1 mic per kg of adrenaline for that child. And you can give a little aliquots of it, 1 mil, if you really need to, and you're stuck and the child's blood pressure is plummeting and you have nothing else to give, and fluid is not working anymore. And that strength will be a weaker strength than the arrest dose adrenaline, and it can be given, obviously, sort of as regularly as you need it, really. We say maximum up to about 2 mils in a go, but I would use it probably in 1 mil aliquots. So that's just a note on that. I've put some in the references at the end. There are some guidelines on it, and there's actually a really nice pediatric emergencies webpage, which I've put a link to at the end, which has a sort of a chat through one of the PICU consultants in, I think it's in Belfast, talks about it, which is quite useful if you want to know anything more. So the question, I guess, becomes peripheral dopamine versus peripheral adrenaline, or that, I suppose that was the question in my mind when I think about peripheral inotropes, because they're probably the most written about, the most used, the most people are the most comfortable with. There was a double-blind randomized clinical trial in 2016 that looked at comparison of dopamine and adrenaline. It was in fluid refractory shock in hypertensive septic shocked children, and they had 60 children in their trial, so not massive. They found that adrenaline was more effective. Now, the outcome data wasn't brilliant, but it does seem to be more effective. It did seem to be more effective in this trial in resolution of fluid refractory hypertensive cold shock. And quite a lot of PICU consultants, I think, if you would talk to them, would probably think that might have been a better drug to start than peripheral dopamine, although I think it sort of depends on what you've got and what people are familiar with in your team. There's definitely a growing evidence base for the safety of peripheral use of vasoactive drugs. So I think that that's important to remember as well. The other thing I wanted to just quickly mention was there are a lot of drugs that, or there are some drugs that have inotropic effects that are not drugs necessarily that we would call inotropes. So calcium given intravenously is actually a really a good positive inotropic effect, and is something that we may well be able to get our hands on in A&E. Something just to bear in mind. There are other drugs that might be go-to drugs that you could use, and those are a couple of just useful resources. Okay, so on to intubation, rapid sequence induction. This is generally what we use in the non-fasted patient. The intention of rapid sequence induction is to prevent aspiration of gastric contents. The typical sort of APLS rapid sequence induction is to pre-oxygenate the child or adult, if you're using it on, with 100% oxygen for at least 3 minutes. You then induce anaesthesia, and then you apply cricoid pressure. And then you administer your muscle relaxant, and then you intubate the child. And importantly, in all of this time, you do not bag, valve, mask, ventilate the child. So the risk of this and the problems that you can get with rapid sequence induction is hypoxia, mainly in children we see, but also with cricoid pressure, you can get distortion of the airway. So in pediatrics generally, and correct me if anyone, if I am not an anaesthetist, so if anyone is an anaesthetist, speak now if they use this regularly in children, but generally, especially in retrieval and sort of in A&E scenarios, we don't use this a lot in children, because of, especially young children, because of they have less respiratory reserve, they've sort of at higher risk of hypoxia than adults are. So generally we use sort of modified rapid sequence induction technique, where you do may well give a bit of bag valve mask ventilation. I think probably more importantly than talking about RSI is talking about the difference between induction of anaesthesia in adults and children, and thinking about what's important when we're thinking about intubating the child in A&E. So children are not young adults, as we all know. Their airway is different because they've got a bigger head, especially young children, especially babies. They've got a large occiput and they've got a short neck. They've got a large sort of tongue with a floppy long epiglottis and a high anterior larynx, particularly in infants. And that kind of comes into the different laryngoscopes that we use in children. So a lot of us who are paediatric trainees will be used to using a Miller, so a straight blade in neonates, because that's what we are trained with in neonates. And people that are adult trainees or anaesthetic trainees, or maybe A&E trainees have done some anaesthetics, will be more used to using a Macintosh blade because that's what you use in adults. And the difference is that the Miller blade's meant to go straight to the back and lift up the epiglottis like that. And the Macintosh is meant to sit in the vallecular and pull up the epiglottis sort of from in front. And because young children and infants have this kind of long floppy epiglottis, that's the kind of theory behind why a Miller blade might be more beneficial, more helpful in these children. However, if it's an anaesthetist that's doing the intubation, it will be what they're used to using and what they're happiest with. And some of them, especially anaesthetists I've known over the years, have used Macintosh blades in younger children perfectly happily. So it's not saying this is a definite one in one and one in the other, but generally in an older child, a Macintosh, and a baby, a Miller blade is meant to be more beneficial. The trachea is short and also soft, so there's risk of damage, but yes. And then breathing, we mentioned before about on the last slide about saturations falling quicker. So children have a limited respiratory reserve and saturations do fall quicker. So just to be aware of that when intubating these children, and that their ventilation is primarily diaphragmatic. So a lot of people will ask you for an NG tube, or may well say, let's put an NG tube in and decompress the stomach. And actually that is really helpful, especially in little children, because if you've got a big, large inflated stomach, especially if this child has been resuscitated and has been being bagged for X amount of time by the paramedics and then by people in A&E resus, then their stomach will probably be full of air. And if that's pressing on their diaphragm, then that's really not going to help their ventilation. So actually putting an NG tube and decompressing the stomach is really helpful. The chest wall is highly compliant, and they've got a functional residual capacity which is pretty low, and it decreases with apnea. So they're sort of very compliant with their chest and at risk of having apneas. Cardiovascularly, they've got, in infants particularly, in babies, the sort of vagal parasympathetic tone predominates, and they can be prone to bradycardias. And so that's why some of you may well be used to giving atropine prior to or during your pre-medications in neonates, and it's something to sort of have ready and be aware of, because it can happen in slightly older infants as well. They can have a sort of vagal parasympathetic response and a bradycardia on intubation. And then cardiac output is rate dependent. So if we're dropping the rate with pre-medications and drugs, then just to be aware that they may well be at higher risk from any drugs that are going to sort of depress respiratory drive or depress the heart rate or anything like that. So what is important in intubation? I guess some of this is from the APLS manual, which is actually quite useful in these sort of things, but most important: person, place and time. So who is the most important person to intubate that child? We all know that intubating children in cardiac arrest, but in peri-arrest situations, particularly in things like septic shock, can be very stressful, can be very precarious, and children can deteriorate, having been sat on a perch for X amount of time at the point that you give the pre-medications prior to intubation. So be prepared, plan, use a checklist, there are lots of them available, and predict difficulties, and have a plan A and a plan B, have a first operator, a second operator, and work out who's going to do what happens if there's a problem, what happens in an emergency. Choice of induction of anaesthesia. So again, I'm not an anaesthetist, but this is sort of from a kind of A&E retrieval point of view. I think it's useful to think about what anaesthesia is. I always remind myself, you've got analgesia, you've got muscle relaxation, and you've got unconsciousness or hypnosis. So you've got different agents that do different things. And it's a combination of the sort of triad of that, which is the kind of true induction of anaesthesia. So you've got IV or inhalant agents for as an anaesthetic. And then you've got sort of this amnesic sedative and hypnotic agents to kind of induce unconsciousness and hypnosis. Analgesics for the analgesia, muscle relaxants, and then other adjuvants we mentioned, atropine, based on concerns about bradycardia and things like that. Have a think about the underlying physiology of what's going on, because actually these drugs, while they may well just, they are inducing anesthesia, they're going to have other side effects as well, particularly cardiovascular side effects in some of them. And so what is the best agent for that situation? And I think this is important even if you're not the person intubating the child, because actually everyone in the room really, the more people in the room that have an idea of what the best thing to do for this child is, the better. And the more you can discuss that sort of thing, the better, really. So this is a long, big table that goes through most of the drugs, I would say. I'm sure some of you, especially if you've done anaesthetics, may well be used to other drugs as well. But a lot of the drugs that we're used to using, particularly in A&E or in sort of retrieval in these children. And I've highlighted the ones that I would say is the sort of cocktail that has been drummed into me over the years as the sort of safe cocktail for induction of anaesthesia in particularly in a septic or hypertensive or unwell child in A&E. So anticholinergics such as atropine, we mentioned the sort of bradycardic response and vagal stimulation. Some of these particularly young babies might have something to be aware of and have kind of maybe available if we need it. And then this is amnesic. This is a sort of main, I guess, amnesic hypnotic sort of anaesthetic drugs. And then you've got analgesics in addition to them, and then you've got neuromuscular blocking agents. So thiopental we may well have used in children who have got status epilepticus, and that has an effect sort of to decrease cerebral metabolism, which is why probably it's used in that situation. Propofol is what a lot of anaesthetists have always kind of over the years been used, and that still is used, and it's used as infusions as well on intensive care to sedate children. But its main side effect, which I'm sure most of us know and has been drummed into us by now, is hypotension. And it can cause quite profound hypotension. So in a child who is coming in hypotensive anyway, even if you're maintaining their blood pressure with inotropes or vasopressors, probably important not to use that. And then ketamine is something that we are probably more used to using, or something that we're more aware of as a good intubating agent in these children. So the reason that ketamine is sort of bandied about, I guess, as a good drug in the unstable sick child in A&E resus is because it's very cardiostable. And what does that mean? It means that it actually, if anything, can cause a slight increase in heart rate and blood pressure and also cardiac output. It has some bronchodilator effects, so in asthmatic children as well, potentially. I mean, there is some slight evidence, minimal, but there is some evidence for ketamine infusion in asthmatic children. And then there's this, which is why people maybe have shied away from it in the past, there's this sort of effect that it can give about emergence reactions in children. And children can get hallucinations and feel very strange and almost dissociated when they wake up from being induced with ketamine. It's also got some analgesic properties as well, so actually you can use it without an analgesic alongside it, especially if you've got a child with a very, very sluggish blood pressure or you're very worried about may have a cardiac arrest and intubation. Etomidate is probably used more by anaesthetists than us, but again has minimal cardiovascular effects, but doesn't have any analgesic effect. Can cause some cortisol suppression as well. And then fentanyl, which if we give analgesics probably is the one that we would go to in association with the amnesic drugs. but bear in mind, again, it can cause some hypertension. We may have seen in neonates it used, and it can cause chest wall rigidity. I've seen that before in neonates, but I've never seen it in a bigger child. But that's a possible side effect, something to be aware of. And then you've got your neuromuscular blocking agents. Probably succinylcholine is the one that neonatologists use the most, although maybe that's changed. I haven't done neonates in a while. Rocuronium is probably the one that we're most used to using now in sort of A&E situations and retrieval service situations. And it's got few cardiovascular effects, so it's quite a safe drug to use in these children that are sick. This is a checklist. I think this may be the STRS checklist. Oh, this is an APS manual. This is just a sort of a go through checklist about before you're intubating, which I think is really useful to have. Most of the retrieval services have one as well. And it's just about role allocation, what to do prior to intubation, a bit about things to think through, sort of tick boxes, which I think actually in a situation where you've got a very sick child in front of you, however much you've done this before, it's really useful to do. So yes, sorry, before I go on, any questions on that? It's very difficult talking to no one sitting in front of you apart from a chat. So I hope you haven't fallen asleep or left at this point, but everyone's still there? Any questions so far? Anyone? No? Everyone's still there? Can everyone still hear me? Can someone just write yes so I know that everyone can still hear me? Yeah, great. Okay, brilliant. Thank you. All right. So STRS dose calculated a very low start dose. Yes, so they start at 10. Is that what they wrote on their calculator? They start at 5. So it's sort of, I think most people would start peripheral dopamine at 10 and work their way up. It said 1. Gosh. No. So I don't know why it said 1 on the STRS. I will have a look at that at the end, Hannah. Sorry, someone's asking a question for those who can't see it on the chat about peripheral dopamine and the drug calculator. No, generally 5 is the lowest I've seen it started at, but most people started at 10. I don't know why on the calculator it said 1. I'll have a look at that and I'll have a chat with you about it at the end. Case 2. So this is a trauma case, something a bit different. So this is a 10-year-old boy brought in by ambulance as a trauma call. Actually, was brought in by helicopter. Ambulance is a trauma call. Was an RTA bike versus car at 30 miles an hour, wearing no helmet. So the witness account was that he was thrown from his bike around 4 meters to a nearby pavement, and the car hit him prior to being thrown off his bike. On scene, his GCS was 9/15, pupils were size 3, equal and reactive, and he was intubated by HEMS who arrived at the scene. There were multiple bruises and lacerations, and there was a large area of bruising on the right side of the head and an obvious deformity of the right femur. His chest was clear and there was equal air entry. He was tachycardic on scene, blood pressure 100/60. You can read it all in front of me. And they had an IO, which they inserted into the left femur, and they gave him just 10 mils per kg as per sort of trauma resuscitation of crystalloid, immobilized, pelvic binder applied, leg was splintered, and they transferred him quickly in view of the head injury to A&E via helicopter. And there was nothing in the background of note. So on arrival to A&E, there was no obvious catastrophic bleeding. His C-spine was already immobilized. He was intubated and ventilated with a size 6 cuffed tube and was easy to ventilate. He was ventilated on relatively minimal settings and a bit of oxygen, but not much. And there was nothing really to hear on the chest, and his saturations were good. His heart rate was 100 and his blood pressure at this point was 135 on 75. His capnography was 3 seconds centrally and 4 peripherally, and his heart sounds were normal. He had been intubated on scene, been given a little bit of ketamine and fentanyl because he was quite uncooperative on scene and confused, and rocuronium for his for the sort of induction of anaesthesia and muscle relaxant, and he was sedated with a morphine infusion. His pupils were size 1 bilaterally at this point, although he was on a morphine infusion, and his blood sugar was 6.2. There was an obvious deformity of the right femur, which was currently in a splint, and there was a large, now boggy swelling of the right side of the head. His abdomen was soft, non-distended. There was some bruises across the abdomen, but there was no distension, no obvious other signs in the abdomen, and there was no obvious other long bone injuries. And he was rolled, transferred to the bed, and there was no injuries noted on the back. So what's everyone thinking about this? What do we think is going on? Anyone mention anything they might be thinking based on what I've just told you? Are you worried about this child? Not worried about this child? Needs a scan. Yeah, so I would agree with all that. So polytrauma, I agree. There's lots of injuries. There's the femur, the head. He does sound still shocked, but also now has a high blood pressure, and we might be worried about raising cranial pressure. He's got a large boggy swelling, so we're worried about his head, and I agree that he needs a scan. So the initial resuscitation, the anaesthetic team secured the ECT tube and were happy with the position, and he was transferred onto the A&E ventilator. Actually didn't need much, so minimal ventilator settings, and his oxygen was titrated for that. He had a peripheral arterial line put in, and actually his invasive blood pressure at the point it was put in was 140/80. His blood gas was maybe a little bit acidotic with the metabolic component and a high lactate, in keeping with blood loss, femur injury, etc. And we were very worried, or the team was very worried about this increasing blood pressure in the context of this large boggy swelling of his head and the history given, and no helmet. So he had a 3 ml per kg bolus of hypertonic saline given, and the plan was for urgent CT head, and the neurosurgical team were called urgently. So this was this is actually not a CT, this is courtesy of a CT that I have found on the internet. But what does everyone think about this CT head? Which looks similar to the CT head. Yeah, very classic extradural, do you agree? With this shape. And you're absolutely right, you can see midline shift if you look at the midline here, and actually very, very small, almost no ventricles. Yes, effaced ventricles, absolutely. Yes, so a large extradural hematoma, which absolutely is a neurosurgical time-critical emergency. So the neurosurgical team were called, urgently reviewed the images actually from CT, and the plan was for urgent transfer to theatre straight from A&E, and for neuroprotection while the team immobilised. Yes, not a great white matter differentiation as well, I agree with Hannah. And the plan was, the advice was that if there was any further change or any concerns about increasing blood pressure or sort of Cushing's response, then or any change in pupils, then for a further hypertonic saline bolus. Actually, the observations stabilized after the first hypertonic saline. The ventilation parameters were optimized to try and get their CO2 up a little bit, and he was transferred to theatre by the anaesthetic consultant and the PICU team. Yeah, so he was intubated. The reason I said BiPAP was just to put on the pressures that he had. You could call it patient-controlled BiPAP. You could call it whatever you like from a ventilation point of view. But he was, yes, intubated and ventilated on 2005, not non-invasive BiPAP, invasive BiPAP. That was, sorry, a question about his BiPAP settings on his invasive ventilation. So yes, he was transferred to theatre by an anaesthetic consultant and the PICU team, and evacuation of clot and insertion of EVD in theatre. So he had evacuation of the hematoma and insertion of an extraventricular drain in theatre, and was transferred from theatre straight to PICU. So a bit about retrieval and stabilisation. Preparation for retrieval. So I guess retrieval, a lot of us think about, especially if we work in district general hospitals, as calling a retrieval team in. But this might be, as in this case, although this case was in a centre where there was a PICU, transfer to another department, e.g. a CT scanner, transfer to another ward, and it might be a time critical surgical transfer, and that may well, all of those may well need to be done by the local team. So there is a sort of transfer pathway or retrieval pathway that may happen by the local team. And then you've got PICU retrieval service, which normally are centralised at a tertiary hospital where there's a PICU. So in London, we have the South Thames Retrieval Service and the Children's Acute Transport Service, and they will cover both North and South London, but generally are one's South and one's North. And then they can transfer to another hospital or transfer to another ward or site within the hospital. So you may well actually call your transport retrieval team if you're a tertiary centre to transfer to another site within your same hospital. The important thing about retrieval, I guess, and this is also taken from just the APLS manual, is that it should be the right child taken at the right time by the right people to the right place via the right form of transport and to receive the right care throughout. So I guess that's just thinking about who is taking this child, where they're taking them to, and what sort of form of transport. So for example, there'll be some emergencies which are time critical, neurosurgical or surgical transfer, in which whilst it would be really nice to have a world in which a PICU team could arrive in 5 minutes, it may well need to be the local team is the most appropriate team, and that might be the anaesthetist, it might be an A&E consultant, it might be you know, a paediatric registrar and an anaesthetist, but it generally will be someone that's trained in airway to manage that child on their transfer. But that's just something to think about. These are guidelines taken. This is the Children's Acute Transport Service, and this is the South Thames Retrieval Service guideline. And they have really nice guidelines actually for managing these children at the District General Hospital prior to retrieval. So you're at the District General Hospital, you've got a child that's sick, you've called the transport service and you're waiting for them. And generally in that situation, you'll have had loads of people there and everyone will have been bustling around and you've given this child fluids and inotropes, whatever you've given them. And then there's this sort of period of, I guess, stabilisation, which you get into. And the question, I suppose, is what to do then while you're waiting. And often you'll find lots of people will leave in that situation and you might just be left there as a paediatric registrar, hopefully with an anaesthetist if they're intubated. And so it's sort of thinking through in your mind, what can I do now? We've done all the kind of emergency bits, so what's next? So stabilisation, I sort of grouped it into 3 things. So monitoring, so that could be basic monitoring and good basic monitoring, or it could be more invasive monitoring if the child needs more invasive monitoring. And then investigation, so they will have potentially had some initial investigations done, but they might need some more investigations at this point when they're a bit more stable. Might be imaging, might be blood tests, might be microbiology, but just making sure some of those are sent. And I give the example of a child that I saw on paediatric intensive care who came in very sick to the District General Hospital, and obviously they did a brilliant job of resuscitating this child, who came in with low GCS and no one really knew why. And someone had at some point during resuscitation presumably sent pneumonia and thought, oh, I wonder, this child was encephalopathic. Someone had obviously thought about metabolic, and it had never got to the lab, or it had got stuck in transit wherever, or someone had put it on the side thinking about sending it to the lab. And by the time they arrived to our PICU, we sent another one, and by the time we got it back, we worked out it was high quite late down the line. So things like that are just important to think about at that point that you're sitting there with this child while the transport team are on their way. What do I need to wrap up? What actually would be really useful to make sure we've sent, and if we've not sent it, will be useful to take now. And then post-resuscitation management. So they've been resuscitated, they might have had a cardiac arrest, they might not have done, and what you're sort of aiming for there. And I guess you're aiming to achieve and maintain a kind of homeostasis, and you're trying to optimize recovery and prevent any sort of secondary injury. I guess that comes into sort of brain injury, which we'll talk in a minute. So if we group it into airway, breathing, circulation, we're talking about renal, liver, and then we can talk about neuro. So airway, breathing, monitoring. So you're probably, if this child's intubated and ventilated, you're going to have an untitled carbon dioxide, or hopefully you will. Saturations and blood gases, so how regularly do they need their blood gases done. And then you can target their oxygen saturations depending on their underlying physiology. So have a think about what's going on. It might be that you need specialist advice for that. This might be a child you're worried about cyanotic heart disease, and you might want advice from the tertiary centre about what their saturation should be. And you probably want to avoid hypoxia, definitely, but also potentially hyperoxia. So don't plough this child full of oxygen when they don't need it. And that kind of comes a bit after the initial resuscitation, when everything's calmed down a bit and you know that they've not had the cardiac arrest that you hope they wouldn't have, and maybe at that point you can wean your oxygen. Targets for carbon dioxide, again, depending on the underlying physiology, so particular conditions, you might have a very sick asthmatic child, you might allow some permissive hypercapnia. You might have a child with raised intracranial pressure where you're trying to maintain a normal carbon dioxide. And the child may or may not be intubated and ventilated, so if they've got a secure airway, that still don't forget about, it needs to be monitored closely. Sorry, if they don't have a secure airway, they need to be monitored closely in case they do need a secure airway. And seriously unwell children often have depressed conscious level, impaired gag reflex, and they might go from being the child that actually was maintaining their airway perfectly fine to being exhausted and needing intubation. So to sort of monitor and think about that. And if they are intubated and ventilated, to think about their ventilation settings, especially if the retrieval team is on their way to you, but it's going to be a while. Make sure you've got an end-tidal CO2 to monitor, or you're doing regular blood gases. And often if you've given a lot of medications and some sort of recovery has happened in the physiology, you may well need to pull back on a lot of your ventilation settings, because you might have started really high and you might need to wean down. So think about why you're ventilating that child. If you're ventilating them purely for the fact, like this child, when there's no respiratory cause, and actually you're ventilating them from a neurological point of view, to try and neuroprotect, or for whatever reason you're ventilating them, they've got a low GCS, etc., then actually you don't want to overventilate them, and actually things like your CO2 become very important. And then your position of your ETT, listening, making sure you've got equal air entry, and doing chest x-rays, etc. Circulation, so monitoring heart rate, blood pressure, ECG, imaging, thinking about echo if you want to think about function and structure, and then more invasive monitoring, so for example a CVP line. Now obviously in district general hospital this may not be possible, but if you've got a very sick child who is on inotropes, and you may have got an anaesthetist who's put in a central line, and your retrieval team may be at another call and they're not going to get to you for a while, you might want to consider things like, if there's an anaesthetist there that could put a CVP line in, because it can give you quite a lot of useful information about preload to the heart, which can direct your decisions about fluids, inotropes, etc. As can having an echo, but obviously that might be a bit more difficult to get at district general hospital. But if it's your tertiary hospital and you've got cardiologists on standby, then why not? And then further fluid resuscitation, if they're responsive or fluid responsive, or there's signs that they may need further fluid, then that's something to consider. And if they've got ongoing inotropic requirement, then think about which inotropes you're giving. And as we mentioned, we talked about inotropes before. Do you want to put in a central line and transfer your inotropes onto a central line rather than giving them peripherally? Keep an eye on your cannulas if you are giving them peripherally. And monitoring, you might want to do invasive blood pressure monitoring. Renal and liver, quick mention of renal and liver. So monitoring, thinking about input, output, urinary catheter, particularly in children with sepsis. It's really helpful to have a proper urinary output measurement. And then bloods, if you've not sent them already, which probably you have during your initial resuscitation, but using these LFTs and coagulation. For renal, it's all about maximizing your renal blood flow and maintaining your renal perfusion and your renal tubular patency. And so you want to ensure adequate filling and adequate blood pressure, which could be fluid if the child needs more fluid and more filling, and it could be an inotrope or a vasopressor, and also maintenance fluid. So if you've fluid filled them and they're no longer shocked, but actually thinking about they're going to sit here and they're not going to drink anything for the next 4 hours until they get to the ICU, whatever it might be. Hopefully it won't be that long, but it might be. Then some maintenance fluids, which I'm sure you all are very on anyway. So the other thing to think about is liver in this, clotting factors, any replacement clotting factors, and any management of bleeding. So make sure they had a group and save done, for example. Make sure that if you need any blood products, you get them ordered. So that's a bit about liver. in this child, which is why I want to mention neuroprotection a bit more, this was a case where actually this child needed neuroprotection. And obviously, if you've got a child that has a massive extradural hematoma like that, this is a time critical neurosurgical emergency. But in the time that someone is on the phone trying to work out where they're going, who is taking them, and getting all the stuff ready for retrieval, there can be someone else that's sitting down and thinking, actually, okay, fine. So in this case, we need to neuroprotect this child, because there will be a period of time of an hour, however long it's going to take for them to get to the theatre they need to get to have the definitive treatment. But in that time, we want to try and prevent any secondary brain injury. So the whole idea of neuroprotection is to prevent, you've had the primary brain injury, you're now trying to prevent any secondary brain injury and protect the brain from any secondary brain injury. So you're trying to maintain normal cerebral blood flow or cerebral perfusion pressure, and trying to avoid hypoxia or hypotension. And the reason for that is, if you think about your what your cerebral perfusion pressure is made up of, it's your mean arterial pressure minus your intracranial pressure. Now, in a child with a massive extradural hematoma, you don't really have much you can do about the intracranial pressure without taking them to theatre to relieve the clot and the bleeding. But you can change your mean arterial pressure. So you may well need inotropes. You might well need to maintain this child's blood pressure higher than you normally would to try and maintain your cerebral perfusion pressure. And you can have targets for that. And then the other thing to remember is that your cerebral blood flow, which is actually what you're trying to aim for, is your cerebral perfusion pressure divided by your cerebral vascular resistance. And so obviously that's something else that we can change, because we know that carbon dioxide at low levels causes vasoconstriction. So we don't want low carbon dioxide. We also don't want high carbon dioxide. We used to aim for permissive hypercapnia, or try and get these patients hypercapnic, thinking that that would help with cerebral vasodilation and blood flow. But actually the evidence now is that you just aim for normal carbon dioxide, not high normal, which is what we used to do. But we can affect that. So if you think through these equations on what's happening in the child's brain, that kind of gives you an idea of how you're going to neuroprotect them. And I'm sure that all of you guys will be very used to this. So things like maintaining head in the midline, 30-degree head up tilt, and that's just trying to maintain your drainage, so your venous drainage, and trying to prevent too much blood being stuck in the box that is the head, which allows nothing to come out. And that's the other thing to think about, I think, in neuroprotection. Think about what's the head's a box and what's in there. So you've got your CSF, and you've got your blood, and you've got your brain. And so if the brain is swelling, what can you kind of control in that? And actually drainage of the blood out, you can control. You can try and take CSF out, but obviously that needs a surgeon to do that. And you can try and control your cerebral blood flow by trying to control your cerebral vascular resistance by keeping things normal. And you can try and keep your mean arterial pressure up, which tries to allow for your cerebral perfusion pressure. So head in the midline, 30-degree tilt, good saturations. So arterial saturations, or this is, I think, taken from STRS, of more than 98. And then good blood pressure, so age-appropriate targets for your blood pressure. And then normal CO2, normal temperature, so don't allow the brain to have to work harder for or have sort of increased metabolic rate by hypothermia. So try and treat that. Identify and treat any seizures. Again, that's trying to sort of reduce any sort of metabolic work of the brain, and try and kind of maintain that by treating seizures. So often we will give these children Keppra as a loading dose to try and treat seizures. So that's something to discuss with your neurosurgical team at the centre that they're going to. Do they want that now? And then maintain normal blood sugar, maintain blood plasma sodium as sort of high normal, and then associate any identified sort of associating injuries. So if there's, like, for example, this child, if they've got a falling blood pressure and they've got a femur fracture that they're bleeding into, you may well want to give blood or prop up their blood pressure from that point of view to neuroprotect them. And then this is just a note on drugs that you might use. So mannitol and also hypertonic saline, I guess, are the two that we're used to. They're both osmotic agents, and they reduce brain tissue volume. So that's trying to reduce the brain component of the bits in the box that you're trying to allow to relieve the pressure. Mannitol used to be the go-to drug. It's been around for years and years and years, and I think probably more people are used to using 3% hypertonic saline now. And there's a bit of evidence that it's a bit better. It's got more effects rather than just being an osmotic agent. It's got some immunological, neurochemical, vasoregulatory effects, and so it's probably more of a go-to drug for raising intracranial pressure now than mannitol. But mannitol has been used for a long time and is some people will be more comfortable with. It might be what you have at your district general hospital, and if it is, then that's fine. And this is just a bit of a note on time critical neurosurgical transfer, which is there's sort of these children really need to get to where they need to get to immediately, because what's going to save their life is going to theatre and having whatever it is that they need doing. If they've got large dilated ventricles and they need a drain put in, if they've got a clot that needs evacuating. So it may well, as I mentioned before, not be able to be a PICU retrieval team. It might need to be your local team, in which case it's working out who is the best person to do that. And these are just some sort of criteria about CT being done, and we shouldn't delay retrieval. So that's quite a lot to cover in an hour. We talked a bit about managing the sick child in A&E and when to start inotropes. And I guess my take-home messages for that are sort of which is the best drug, and think about that rather than just what do I have available. Respect inotropes, but don't be scared of them, and that they can be used peripherally safely. Intubating in A&E, be prepared, plan and predict difficulties, and make sure it's the right person, the right place and the right time. And then for stabilisation retrieval, monitoring, investigations and post-resuscitation management, and think about what you can do in that period of time before the retrieval team arrive, and think about the underlying physiology, what's going on. So yes, we've covered quite a lot, but does anyone have any burning questions that they would like to ask? Thank you very much, Hannah. That's very kind. Any questions? No questions? Great. I think, Hannah, you mentioned about the STRS guidance. I will try and maybe get it sent out. That might be the best way to do it. Or the other way to do it is just have a look. If you look up STRS retrieval calculator, and I'm pretty sure that we don't start dopamine, although I'm used to using the CATS retrieval calculator, but we don't start it as one. But yes, I don't think that would do very much, apart from maybe be a renal dose dopamine, although I don't ever really use renal dose dopamine, so who knows. And this was just a funny picture for everyone who might still be there. This is the retrieval ambulances in America. Can you believe it? How amazing is that? Don't we all wish that we had more money in the NHS? And there are my references, for anyone that wants to. Okay, great.
I think someone said, oh, Kelly has a question. She's just typing.
Yeah. Are there any common frustrations when retrieval teams rise and things? So I think it's very difficult, isn't it? I think that we're all aware, when you work in PICU, you're very aware that it's very difficult at district general hospital, and I have worked in district. I've done my ST4 and 5 and the back end of nowhere where you have nothing. And yeah, I agree with Harris. Yeah, please don't shorten the ETT. There's absolutely no space left. Other than that, I think just those sort of like tying up loose ends. I think that it's not so much about the initial resuscitation. We appreciate that, you know, I say we, this is the royal we, I will be working in a DGH soon. I think retrieval teams appreciate that there is limited amount of what you can do, and that, you know, it's never going to be a perfect world, and it's not PICU. But I think that things that I have found on the PICU side a little bit frustrating are when the other loose ends aren't tied up. So there is always a period of time, or there's often a period of time when the retrieval team are on their way, and there's often a bit of time that you can do other bits, and things like tying up all the investigations, making sure everything's sort of done and dusted, making sure that you know you've got the full history from the family, things like that. You're right, Harris has said avoid pediatric propofol induction. I think that that's probably been drummed into a lot of us by now. I think that hopefully you're not working at DGH where they need to still use it, but things like that, trying to also be aware that in little babies, it might be the pediatrician who's the most confident person to, or competent person to intubate that baby. And so working as a team, that sort of thing. But no, there's nothing really, I mean, the usual. It's difficult in a DGH, we appreciate that. So yeah.